Hello, my name is Sharon Karlsberg. I'm coming to you from ASCO 2016. I'm a principal with ZS, a global sales and marketing firm, here today with Dr. Roy Herbst. Dr. Herbst is the Director of Medical Oncology at Yale Cancer Center at the Yale Cancer Hospital. Dr. Herbst, thank you for joining me today.
My pleasure.
As you know, there have been many exciting developments in the field of immunotherapy, particularly when we look at the new anti-PD-1 and anti-PD-L1 agents used for the treatment of non-small cell lung cancer. Last year, you introduced a session talking about the various tests and agents that are available, and you mentioned that you thought PD-L1 testing was not ready for prime time. Is that correct?
Yes, I discussed Checkmate 57 last year, which was the non-squamous trial of nivolumab versus docetaxel, which was positive in all comers with an embedded biomarker. But at that time, the biomarker was only done on a small fraction of the patients, or an incomplete fraction, that's probably more accurate, and the fact that there was no clear distinction for a negative biomarker regarding whether or not one should get the drug. It was my conclusion at that time that we probably we could give the drug to all patients. Physicians and patients should discuss the situation and make their own decision, but there was not enough data at that point to exclude patients from the trial based on the biomarker. Since that time, the biomarkers have improved, and there have been other studies which now are part of the debate.
Knowing what you know now, Doctor, how do you think your perspective on PD-L1 testing has changed with the data that's come out in the last year?
Well, every drug has been developed with its own companion biomarker, so you really have to look at drug-specific trials. Should you test all patients or not? What about the negative patients? They weren't tested in that trial. My opinion on this is that the biomarker does matter, and PD-L1 can help you in your decision as a clinician. If you have a patient who you know is PD-L1 positive, you know that they're more likely to benefit from an immune therapy agent. However, given available data, if they're PD-L1 negative, you could still try a PD-L1 or PD-1 inhibitor, and there still might be a benefit.
Well, maybe, I appreciate your perspective being so embedded in this research yourself as an investigator. For oncologists in common community practice, however, they may be looking at the data and be a bit bewildered. There's one drug that requires a diagnostic where we can clearly predict a positive response for those high expressors, and there's another drug that seems to have a benefit regardless of PD-L1 expression. What would be your rationale for testing the community?
The drugs are no different. And in fact, there's an advantage with pembrolizumab in that it's given every 3 weeks versus nivolumab every 2 weeks. The markers are different. So it's just the way the trials have been done. But that's life, that's what you have. This differential is going to become moot, as we move to the front line. My patients always say, "Doctor, this is great, I'm doing well on this immune therapy. Why did you give me all that chemotherapy first and put me through the ringer?" So we're going to see frontline use. And in the frontline use, those trials that are now cooking, there's one with nivolumab, one with pembrolizumab that we know have completed enrollment. We're awaiting maturation. Those trials all required a biomarker positivity to be enrolled. That's important because it means that we're going to start screening patients for PD-L1 because we're going to look at PD-L1 frontline. So then we'll know who's PD-L1 positive or not. So in that case, many people will be getting it up front, at this point, and depending on the results of the trials, that may or may not be pembrolizumab or nivolumab. Both will require testing. In the second line setting, I don't think we're going to see much testing right now. It's quite clear PD-L1 testing, while it can help determine who's going to benefit, if you're going to use the drug anyhow, why would you do the test? There might be situations where you want to test.
So you've said two things, if I can summarize. You've said, one, there's no need to test today for relapsed patients because we have a drug that works regardless. It has benefit regardless of PD-L1 status. On the other hand, we now have different options, immunocombination therapy, other therapies that we might try based on a patient's PD-L1 status. What would be your advice to, say, a community oncologist now, a relapsed lung cancer patient? Do you test, do you not test, and what's the benefit?
I think more important than worrying about which drug, it's like Coke versus Pepsi. Yeah. I think it's more important now to think about what we're going to use to enhance both so that they taste better and that they're better effective in patients' tumors.
So would you advocate for PD-L1 testing to choose between, say, a monotherapy versus a combination immunotherapy? What's required?
Yes, if for example, like with Medi 4736, now known as durvalumab plus tremelimumab, where we are seeing activity in PD-L1 negative patients. So there you might say, well, if someone's PD-L1 positive at a high level, give them the PD-L1 inhibitor durvalumab alone. But if they're PD-L1 negative, maybe they need the combination. And if it's been shown to work, then it's worth the clearly added toxicity of using two drugs versus one. because the one thing we haven't talked about yet, but it's sort of obvious, is that when you activate the immune system, you activate the immune system all over, not just in the lung tumor, wherever it might be.
My last question, doctor. How does it change the conversation with your patient when you have the PD-L1 status available to you as part of your treatment equation?
If I had a PD-L1 that was high, or or at least in the positive range, I'd say, yeah, no doubt, I feel very confident this is going to work. For the patient who doesn't have that, I might say, well, we can use this now, and I'd be a little bit more describing of the fact that there are the other options. But then again, I'd still use it, and I would still provide hope to the patient, because I'm not, if I'm going to use it, I'm going to hope that it works. But I'd be honest for people who want to know, and most do, and if not, you always have that discussion with the patient. I'd say the chance of it working is on the lesser side. So it allows me to go through the risks, benefits with the patient, with the family, as they want to know it.
Great. Thank you so much.
Thank you.